This episode of Two Lost Souls is brought to you in partnership with langbuddy.ai.
Therapy, as we know, is all about language. Words and their meaning help bridge that gap between us and our clients' understanding of the world.
However, like anything in life, practice makes progress. And if you're learning a new language, LangBuddy is just the tool for that. LangBuddy is an AI language bot that you can talk to on WhatsApp. And it's not just about speaking either. It's about listening and understanding. LangBuddy can send you voice notes so you can train your ear to your chosen language.
That's amazing. Is it available in French?
Oui.
Spanish?
Si.
Lithuanian?
Tape.
Japanese?
Hai.
Swahili?
Ndio. In fact, there are over 300 languages and regional dialects available, so we could carry on doing this all day.
Well, luckily, given that it's an AI chatbot, you literally can. There's no waiting for it while it sleeps or eats. The learning never stops. And given that therapy and learning go hand in hand, we are pleased to offer listeners of Two Lost Souls 10% off your first month of LangBuddy by going to langbuddy.ai and using the discount code Two Lost Souls at the checkout. That's langbuddy.ai with the discount code Two Lost Souls.
LangBuddy. Improve your language skills by chatting with an AI native speaker.
Hi, I'm Ravi.
And I'm Shell,
And you're listening to Two Lost Souls.
the podcast that guides you through the journey to becoming a CBT therapist.
Good morning, good afternoon, and good evening, whenever and wherever you are listening. Welcome to the Two Lost Souls podcast. The title of today's episode is Working with Comorbid ADHD. My name is Ravi Amrath, and in today's show, we will be discussing top tips for trainees and established therapists on how to work with comorbid ADHD in a talking therapy setting. But let me begin by saying that this is your podcast guide to surviving a high-intensity CBT course. We pride ourselves on creating a safe space for trainees, qualified therapists, and those who are generally curious. Honesty is our policy, and we tell it how we see it, but we'd love to hear your views too. As usual, I am joined today by someone who currently works for 2 different NHS trusts, 1 university, and an online therapy service, yet still has the time and energy to join us here in the therapy room. It's the superb Michelle Sudbury. How's it going, Michelle?
It's going all right, thank you. I have the time. I don't know about the energy, but I'm here. So.
I was about to say, it sounds incredibly exhausting.
Yeah, it's a lot. It is a lot, but I'm enjoying it. It's a lot of variety now, so it's all good.
And fulfilling, it sounds like, given that variety as well.
Yeah, it is. Yeah, it is. Very much so.
Yeah, and I know that you're also working with quite an established member of the ACT and CBT community at the moment as well. I know I'm fangirling over it, so I'm very jealous of you, and I know I'm going to be asking for your autograph soon as well. So how's that been?
It's been great. Are you referring to Rich Bennett?
I may be referring to Dr. Richard Bennett, yes.
Yeah, that's what I should have said, isn't it? Dr. Richard Bennett, not Rich.
I mean, you're on those sort of terms with him now, you see.
So basically, I've been really lucky to do a couple of days supporting some of the new trainees with a bit of supervision, just on an ad hoc basis, but it was fabulous. Really enjoyed it. Very open to more of that, Rich, if you're listening. Little plug. But yeah, it was amazing. Really loved it. And that's kind of what I'm hoping to carry on and do now, a bit more supervision. So.
Oh, absolutely amazing. Well, that's really fantastic, and I'm really glad you're having a good time with it as well. And I mean, while you're getting a little hint in there, Shell, I'll also say that, in the future, Rich, there's someone else here who could be open to that stuff as well.
Who's that, Ravi? Who might you be referring to?
I might be referring to myself, potentially.
Oh, okay.
However, I still need to get a few hours under my belt first, I think, before I'm anywhere near ready to do that. Before we move on with the show, let me just remind you out there that if you have any particular questions or topics that you would like to see covered on the Two Lost Souls podcast, reach out to us on Twitter at TLS_pod or by email at twolostsoulspodcast@gmail.com. So we are joined in the therapy room today by the psychologist and CBT therapist, Dr. Helen Moya. Helen, how are you?
I'm good, thank you. Thank you for inviting me, Ravi.
No worries at all. I mean, just to start with, and before we get into the sort of main topic of discussion for today, I firstly want to say a big thank you for the resources that you've collated on your website. Actually, I found them a huge help during the training process. And I was just wondering, just before we begin, whether you could just give people a bit of a rundown as to where they can find more about you, where they can find those resources, and I suppose what you'd like people to get from using them.
Yeah, thank you for that. Yes, I have a website and it's called Moya CBT, Moya, MOYA, CBT.co.uk. And that is the website for my private business. But previously I was the course director of a CBT program. So I do have a clinical academic background. So when I did set up my business, part of the remit was to provide materials, resources for therapists and trainees to help them in their career journeys, and information, to sort of signpost and help people on that journey, because I felt there was a lack of information. So there are various resources on the resource page, including things like preparing for interviews and how to use some of the CBT protocols, breaking it down into hopefully, accessible language, etc. So yeah, there's lots of things on there. There's a lot of self-help guides as well, including one to ADHD, which I'm sure we might come back to at some point this evening.
Definitely. And that was part of the inspiration for this episode and for actually asking you on to discuss that today, actually. And one thing just to discuss there as well, you mentioned the resources in relation to some of the treatment protocols for anyone who's listening right now and is in that stage of their journey where they're actually on the verge of qualifying, or they have just qualified and then they're sort of in that time period where the stabilizers have come off and they're maybe feeling like they're having a little bit of a wobble. I found that those guides are really helpful, actually, just as a really nice refresher of the course as well, to make sure that you're still keeping your practice in line with the evidence base, which is really cool. So thank you again for that. And moving on to the main topic of our discussion today on ADHD. So just to kind of get started from the ground level, really, and for people who may not have worked with clients who have experienced comorbid ADHD before, what are the general sort of signs and symptoms that someone would typically report if they're experiencing that alongside another mild to moderate mental health condition?
Well, that's a really good question and not a simple answer, because I think most people would expect a simple answer, i.e. people who find it hard to focus and maybe a little bit sort of hyperactive. But it really does include a really large number of symptoms, for want of a better word, if we're taking a more medicalized kind of view of it. But when we are trying to conceptualize any mental distress that people experience, of course, if we are talking about diagnosis and symptoms, that belongs in a certain way of understanding somebody's distress, doesn't it? So yes, we are going to be focusing on like IAPT and delivering CBT. So we are within that model. So although I'm giving a sort of like a roundabout answer here, I guess from my experience, a simplified version is where problems can occur, if that makes sense. So yes, clearly, if you look at the diagnostic criteria, it is split into sort of like the attention deficit part, which is the difficulty focusing, zoning out, getting bored easily, getting distractible. And they are, typical kind of symptoms. But there are a lot of other ones. And the hyperactive side, I think people tend to have a vision of sort of like very overactive children, boys in particular. But for me, the hyperactivity is very much internal. It's the busy head. It's the, the very sort of that buzzing in the head. It never kind of switches off. And it doesn't have to be negative either. It can be quite exciting and it can be quite, stimulating. But they are sort of like typical things, and impulsivity, poor impulse control. So a lot of people who don't know they've got ADHD can very easily misdiagnose themselves, or other people can misdiagnose, because unless you see it in context, it's very hard to really fully understand.
Definitely. I think, speaking about that sort of element of self-diagnosis or misdiagnosis when it comes to self-diagnosis. And this might be a bit of a difficult question to answer, but in terms of where do we as practitioners sort of stand with that? So acknowledging that I think a lot of clients that we are seeing at the moment are at a stage where they're attempting to gain an ADHD diagnosis, but acknowledging that due to pressures on services, they're not really able to get to that point particularly very quickly. And so therefore they are mentioning when they seek treatment that they feel that they may have ADHD or that they have self-diagnosed with ADHD. I suppose what is a practitioner to sort of do with that in terms of the legitimacy of that self-diagnosis?
Well, legitimacy, who is judging? Because I think that's one of the issues, isn't it? When we have debates, who is saying that something is valid or not? I think it's a human condition to be curious and want answers to why you're suffering. And it is it's a lifelong condition. So depending what age the person is when they are self-diagnosing or seeking help, the likelihood is they've suffered and it's had an impact for a number of years. So I don't ever want to be arrogant enough to suggest that somebody shouldn't seek that help, regardless of what the outcome might be, because, for some people it's enough to self-diagnose, and if they understand that it could be ADHD, then they might do their own research as to looking for strategies to help themselves. And so different people will have a different response or a different goal when it comes to diagnosis, or whether they even use that word at all. It's identification. It might be, somebody's talking about something that really resonates with me. And they may be curious, or they may want to go further and get that validated by a professional. But my view is that it's enough to read and identify or talk to it, and then you've got choices, haven't you?
Yeah. Helen, I was just going to pick up on that, if that's okay. I think one of the things that I've experienced when I've been working with clients is that very often, although self-diagnosis feels sufficient and it helps them to make sense of what they're experiencing and living with, one of the biggest frustrations I've kind of experienced with clients is that it excludes them without having that official diagnosis, somebody having assessed them and telling them that is what they're experiencing. They feel excluded from accessing support services that might be able to help. And with the backlog and the kind of chronic issues that people are having, trying to get that funding to go ahead for adult diagnosis, that's causing a lot of distress, I'm finding it, and really exacerbating their existing mental health conditions anyway. So the depressed client waiting, striving for diagnosis to try and access that appropriate level of help, and then being told they can't. And our service, I don't know if this is the same nationwide, but this really shocked me. We've had clients who've sought private diagnosis and have funded it themselves, and then have been told that because it's been privately funded and it hasn't gone through the NHS, they're excluded from accessing appropriate support services anyway, because they haven't gone through the NHS process. It just feels so frustrating for everybody, I'm sure.
It's an absolutely dire situation. There's no doubt about it. So, yes, I wasn't undermining or suggesting in any way that going for an official diagnosis, because that's the route that I took myself. And there are so many grey areas to this whole situation. So you mentioned about, the waiting list for a start being so long. So actually getting on that waiting list, being taken seriously is a massive issue, because in my opinion, being believed, even if it's you suspect that might be the case, is often the first challenge. Is having somebody in your corner saying, well, this is what you can do if you want to have it, to get that checked out, have an assessment. So then you are faced with the long waiting time in the NHS. I think most people will know by now of the Right to Choose scheme, which is sort of supported by Psychiatry UK, which have then been commissioned to do some of the ADHD assessments by their trained professionals. So So for the patient, that means, accessing it free as you would, but it means that the waiting time can be substantially reduced, because it overcomes some of the difficulties with postcode lottery issues, because it's actually at the point at which you put your name on the national waiting list, you are then, provided with support in that way, rather than in your local area where the wait time might be 3 years. At somebody else, it might be 1 year. But at the point at which you add your name to that waiting list, then that enables you to have a overall shorter waiting time, which is more equitable and, across the whole country. So you can do that. And then get assessed, and if you are diagnosed, then access support directly from that pathway. And also, if you are on the Right to Choose, the average waiting time at the moment is about 6 months, which compared to some sort of local areas is actually not so bad. So it's roughly 6 months, and within that time there are services that are provided to kind of give psychoeducation, give some sort of self-help resources, and some online sort of help as well. So it is getting better, at the NHS level. It really is, but it is still, it does still depend where you live and how you access that service. And then you mentioned about people going privately. I had to do that personally. And that was only 2 years ago, less than 2 years ago. And the reason that I chose that route is because my son was waiting for an assessment in school, which I'm sure we'll come on to as a feeder issue into adult ADHD, waiting for him to be taken seriously, to actually get to the point of the school making that referral. I felt that because I'd had suspicions from my end, that if I, as his mum, had the diagnosis, that might give a little bit more weight to my arguments for, sort of like pushing for that. And actually, it was through him displaying signs and symptoms is that made me look at myself, which I think is a common route for adults with undiagnosed ADHD coming to that conclusion because they see things in their children. But so for me, I did go the private route, but luckily I was with a provider where the NHS does recognise the diagnosis. That is an important issue for anyone listening because, you do need to be sure that can be transferred. The care can be shared or passed over to the NHS at a later date.
Yeah, thank you.
I'm really glad you spoke about the Right to Choose programme as well. So full disclosure, I'm actually on that journey myself as well, not in terms of Right to Choose, but on the NHS waiting list for an assessment now as well. And I think if anyone is listening who is also considering that or considering these pathways that may be available to them, I think it's important to know as well that in my experience, I found that some practitioners can also be quite reticent to make use of that Right to Choose programme as well, and will kind of mention a lot of the sort of CCG or primary care board campaigning that they will have to do to kind of fight that case as well. And I suppose my plea for anyone out there will be not to be perturbed by that, particularly if the waiting list, that the difference in time is that strong and that significant, then I think it's something worth persevering with. I'm quite lucky in that I had the luxury of studying a psychology degree all those years ago now. And way back then, I say way back then, it was only about a decade ago, but there was a lot of discussion about the causes of ADHD, and there was a fierce debate back then as to whether it was a thing, so to speak, or what the contributing factors to it were. And I'm just wondering what that landscape looked like at the moment and what developments there have been in that side of things.
Yeah, that's a really good question. And I think it's one that will persist to have various theories and positions. I think there's been, if we look back in time, even over the sort of different versions or editions of the DSM, there's been some allusion, hasn't there, to, this sort of profile of symptoms, if you like, and there's been an association clearly with the brain, and, sort of like different theories as to what's happening in an ADHD brain versus a non-ADHD brain. And there have been various theories about that over the years. But I think consistently the dopamine, the sort of like the lower levels of dopamine is still talked about a lot. But for me, I think the threat system, they sort of like it's triggered more easily, which means then that you get more adrenaline sort of like pumping, which we know puts you into fight, flight or freeze. So that means that impulse control can be kind of affected by that. So if you've got a load of adrenaline buzzing and, it doesn't have to be a negative experience. Whereas if we think of fight, flight or freeze in terms of anxiety and it's fear driven, with ADHD, it can be very different to that. It can be the same if you can still feel anxiety, but I would call it a nervous agitation. And that's how I distinguish it, because it's an under the surface constant reverberation, which can be quite exciting. But it can be really quite stressful as well. So I liken it always with people I work with to the threat system, the brain, the sort of fight, flight, freeze, and how there's a little lag between the amygdala and the frontal cortex. So trigger, I haven't got time to think, I'm going to react instead. Does that make sense? And that to me makes the most sense. So, and it is implicated still in all of the medical research that the, adrenaline is one of the key kind of, chemicals, if you like, or there is an excess of it, or more of it is produced, which would make sense of the stress reaction as well. That's if you're stressed on top of having ADHD, that is going to increase those symptoms.
Okay. Alongside that, you spoke earlier, Helen, about some challenges that your son experienced in terms of school assessments and things like that as well. And I suppose relating that to adult ADHD, what are the reasons that there's been a bit of an uptick in the amount of people seeking out ADHD diagnosis or treatment as an adult now? What things have contributed to that?
Well, I think one thing is that clearly it is talked about more. I mean, so people are describing experiences, which to me I think is, hearing somebody's story is far more illuminating, isn't it, than, reading, a set of symptoms, which people can argue we all experience that to some degree. I would argue that the attentional deficit bit is kind of something that everybody could identify with. The hyperactivity bit, the internal hyperactivity, I don't think is everybody has a bit of that. I think that is distinctive, in my opinion. Now, there's no research that says that outright. But going back to the question, why is there an increase now? So yes, partly I think it's, hearing stories and identifying with it. But going back to the school side of things, I would have thought and hoped that by now, with training and understanding of neurodiversity, because let's give it a name, that has become more talked about. So, and that transcends different services. So healthcare professionals, teachers should be more aware for looking out for signs and impact on a person's, child's education, their, sort of needs, their learning difficulties. And then as an adult, if you're more aware of these issues, and you go to a healthcare professional, then having that understanding of neurodiversity as a broader kind of, topic, hopefully helps people recognize these are lifelong conditions. And that means then at any point in time at which it's discovered or suspected, that you would hope then that whoever you go to with that suspicion would have the knowledge to be able to recognize it, or, as we said earlier, validate it, or at least take it seriously.
Got you. So it sounds like then what we're essentially seeing is kind of a system playing catch up a little bit, given that, again, a decade ago, I don't think the term neurodiversity was ever really heard of or acknowledged or even really existed. So it sounds like what's happening now is that the system is actually having to, and maybe not always successfully, work in overdrive to catch all the people who are now aware of these symptoms or conditions that have existed for such a long time, and now realise that there is some support that is available to them.
Yes, yeah, absolutely. I really do believe that.
So, Helen, just continuing the discussion around assessment rates, etc., and the uptick in people seeking out assessment at the moment, what do things look like in terms of, or sort of the gender breakdown of people who are seeking out assessment at the moment? Is that massively different to what it's looked like historically?
Yes, I think currently we're hearing of much larger numbers of women who are seeking an ADHD assessment in adult life. And yes, this is very different to how it has been, over the preceding decades, because I think it's only becoming more recognised with the discussion that around neurodiversity and how that presents differently in males and females. And that was certainly my experience as a little girl, was that, it's often the broad difference is that girls often have a more internalized experience of the symptoms, which the distress then becomes like more internalized and masked. Whereas in boys, that if we think about the adrenaline theory, that the adrenaline is often burnt off by running around and climbing trees. But in girls, you tend to go on the freeze mode, and that's really quite distressing. So the presentation in a girl for myself would be the almost dissociating in the classroom. It wasn't even just daydreaming. It's just like drifting off, especially, if you're in situations that were quite anxiety provoking and you didn't really understand, what was happening. So yeah, very much an internalized sense of the hyperactivity, that sort of constantly, reverberating mind, lots of thoughts. And then, of course, as you grow up, you never even consider it's a condition. You just think that's how you are. And then in puberty, there's other changes between boys and girls, and that is when, the hormone things happen. In girls and women, there are 2 points at which symptoms tend to escalate. So when you start your periods and when you end them in menopause, they are extremely distressing times. So you will probably find that girls with ADHD may have very adverse reactions emotionally to that. And that's what happened to me. I was a very quiet, internalized girl until I hit puberty and I turned into a raging, angry volcano. And to be honest with you, that stayed with me for a number of years. And the thing is that it's not sociably acceptable for a girl to be angry. So you then socializing, that becomes, difficult. A lot of girls and women are falsely diagnosed with emotionally unstable personality disorder because that lack of regulation. Whereas actually, some of the baseline symptoms of what used to be called borderline personality disorder probably don't exist, but a lot of the emotional dysregulation does, and it can be very, very easily, sort of like misdiagnosed or, misconceived. And that's a horrible, for anyone. It's a very difficult label to carry around with you, or question mark to have over your head. So I think now with women going for assessment, it's starting to be a light bulb moment. Oh, now then I'm getting it. That's what was happening when I was young. And that's why I'm finding it hard. I found it hard in relationships all this time, or, or my moods have been really all over the place. Because never really learnt to regulate those emotions. So I believe that now I'm really hopeful that a lot of women will start to understand, what was happening all along. And that validation is extremely important, I think.
Are you finding that women are getting to, you mentioned the hormone thing there, and that was really interesting for me. You're finding that women are getting to kind of that, late 30s, early 40s, perimenopausal, menopausal age, and then thinking, actually, what's going on? I'm kind of not happy with the way that I'm reacting to this, or it doesn't feel right. And then they're seeking some support. Is that what you're
There is a sharp, there is a sharp increase at that age. Yes, absolutely. And now we are hearing more about the menopause. Some women are just putting it down to the menopause and not questioning that actually, if you've lived with ADHD for that number of years, and then you are going through really what is like, assault on your body and your brain at that time, is an extremely stressful time. So, and then if you're already prone to mood disorders on top of that, I knew I was going to have a bad menopause, and it really was atrocious. And I didn't know I'd got ADHD then, but looking back, it makes so much sense why, I literally had to go off work for 8 months. And that was, it's never happened in the whole of my career. So I had a really bad crash. But looking back, it makes sense in terms of all of that hormone, because you lose estrogen, and estrogen actually keeps is helpful for ADHD, apparently. I'm not an endocrinologist, but when you lose the estrogen, it does actually affect the brain chemistry in a way that is likely to have an impact on symptoms. That's what one theory. I can't say, back that up with a name, but, clearly there are interactions there that are going to, sort of have an impact, aren't they, on mood, on functionality, how the brain is working or not working. And, I think it's a combination of things. Plus, a woman may have learnt strategies, which we do, and those strategies become, harder to employ when you've got menopause symptoms. So, it does kind of make sense that then, if somebody says, oh, well, have you thought could be ADHD, then, it's an alternative explanation, isn't it, to follow up?
Oh, that's so interesting. So interesting. Thank you.
Zooming in on the sort of talking therapies side of things, what would you say are some of the challenges that present when working with individuals who exhibit ADHD symptoms alongside those sort of mild to moderate depression or anxiety symptoms?
Yeah, right. So, if the person does that, there are, if you think about, let's say, IAPT or any kind of therapeutic situation, you've got 4 scenarios, really. If we think of it as the person comes to see us and they know and you don't know that they've got ADHD, or they suspect but you don't at that point, or you suspect and they don't, or you both suspect or neither of you do. So you've got 4 possible scenarios, and it's our job as a therapist to cover all of those bases. So we're observing if the person hasn't mentioned it, but we're seeing some signs like really violent tapping of the leg or something, or it could be anything, or sort of losing a train of thought, which doesn't match their presenting problem, or, being extremely distracted or jumping in, or, which doesn't fit the presentation. Then we need to be looking out for those things, but not jumping in and labeling it. Oh, have you ever thought you've got ADHD? We're processing that, we're logging it, and we're doing what we always do in an assessment and beyond, which is trying to build a bigger picture around what we're seeing in front of us. So there's a lot that goes into it, but as therapists, we are very skilled at doing that. But it's those different scenarios which we need to be aware of. And sometimes the person is coming in saying, I think I've got it. And you're looking and you think, I don't think you do. And then that's or the other way around. Or like I say, you both discover it as you go through, and the GAD treatment doesn't work, or then another layer appears. It's all part of the process. And I would say I do that with absolutely everyone, whether they've got ADHD or not, if that makes sense.
Definitely. I like the concept of that you just described there, almost like a Johari's window for ADHD, which I quite like.
That's it. Yeah.
I was just going to ask as well, on the awareness issue, what do you make, Helen, of what I consider to be the lack of training, particularly for our kind of newer high intensity, low intensity therapists coming through courses at the moment? I mean, I only qualified like 5 years ago. I don't recall us ever working or learning about neurodiversity as part of the training. And I remember doing a small piece of CPD, maybe a year or so afterwards, 2 hours. And that was kind of the extent of my knowledge. I don't live with neurodiversity. I don't have family members who are neurodiverse. So for me, it's very new. And it was so interesting hearing you saying that we're going to have these scenarios that could play out in the therapy room. But what if we're not looking for it because it's not in our awareness and we've got no knowledge of it? What do we do about this?
Right. Well, you touched on a really fundamental question about training. And if we think back, now we're sort of 15 years into IAPT, aren't we? If you think back to 2008, where it was set up, it wasn't really aimed at people with neurodiversity. So we have to remember that the core curriculum was based on mild to moderate anxiety and depression. And so that made up the curriculum, basically, and that alone was jamming it into a year. We can sort of make cases for, sort of including things about working with older people, because that's not on everybody's curriculum either. And so it was a case of having to cover core elements that would enable a trainee to become skilled in working with depression and anxiety. So we have to put it in context, and that's how it was when the curricula was set up. That has changed over time. There are, the BABCP even are now sort of like recognizing gaps, and and the new guidelines, the new core curriculum does cover diversity, and diversity has become a topic in and of itself. But you're right, in the actual training, very little is taught. Beyond that, still, I'm finding that there is very little, because previously it would have been seen to be part of specialist services, so tier 4 or tertiary care. So that's why, a lot of mainstream therapists probably haven't had that. But now, of course, it is seeping into every service. So there is absolutely a need for training. And some of the documents that I've produced are to assist therapists with learning some of the basics. Of course, it doesn't replace having really good quality face-to-face or online training. But I write my guides in a way that hopefully it goes beyond a set of symptoms, that there are subtleties and lived experience examples, which then enable a therapist to see a bigger picture, if that makes sense.
Yeah, it does. Thank you.
Alongside another mention of the resources page on your website as well, which I think, again, is a huge help, particularly for topics like this. I think a little bit of a self-serving plug as well. We know that the accreditation liaison officers at the BABCP have said that listening to podcasts like this counts as a form of CPD. So hopefully,
oh really? That's brilliant.
Yeah. So hopefully this is solving some of that problem and starting to help with that change in tide. And if the BABCP would like to send us a check, then we're not going to.
Well, I know that there's
not going to haggle too much with that.
There's recently been one of the CPD events on the BABCP, but myself, I do training as well, because I'm obviously very passionate about it, and so I have done 2 runnings of it so far, and the next one is going to be face to face, and it's a whole dayer, and that I am plugging here. It's on the 28th of April, and it's in Nottingham. And it's in a lovely setting, and I want to make it a good experience. And so that doing it face to face, I think, is, going to make it interactive. And, I'm really, really looking forward to that. So, you can get details of that on my website.
Yeah, plug away.
It's on the resources page right at the bottom. It's an Eventbrite link. But so, yes, I'm hoping to, develop and expand on the training, because so far it's been really well received, and that's great to hear.
There's an audience for it, Helen, isn't there? I mean, we kind of want to develop, we want to meet the needs of our clients, don't we? So there's an audience, and there's definitely a need. So, absolutely, plug away. Perfect.
100%. I'd encourage all the listeners out there to go and check the resources page on the website, and check out that Eventbrite link as well. And regardless of whether you're a trainee, whether you're newly qualified, or whether you're actually more senior in your role, and even if you're in, I suppose, a more sort of service design role, if you're in a member of management, training is a really important thing to put in place for staff members in your service and fellow therapists. And I suppose with that in mind and alongside that, what other considerations do you think need to be made on a sort of service level to ensure that they provide services that are accessible and useful to individuals who have ADHD alongside mild to moderate mental health conditions?
Well, I think a lot of that has to do with what's bringing the person to the service at that time. And we know that because often there are limits to time in terms of what can be worked on, how detailed the therapy can be at any given time. I guess somebody with ADHD we know is going to be more likely to experience some of the common mental health problems as well. But whether they would access, I'm guessing, and in my experience, they would access the service when they are actually in a period of low mood or anxiety, But coming to, I've not personally known somebody come to just work on ADHD, but I think you have to formulate that in terms of how you make sense of the presenting problem. But I think some people's approach might be the sort of like the cut and paste approach, where you are seeing a cross section of a problem and you kind of like, cut part of it out and work on it, if that makes sense, and paste it back in and hope that has a knock-on effect to the bigger picture. And I've worked like that myself. If I've been in IAPT, because I, recently worked in IAPT for 4 years, I took myself back there to kind of like get at the cold face again, And I actually think there's some benefit to having, if you can within the IAPT service, have multiple short periods of therapy, which is the revolving door. And I know that's controversial, but I actually feel a soundbite of therapy, it directed in the right place to give symptom relief and help the person go away and consolidate, then come back for the next layer, can be effective. Not for everyone. I'll say that clearly, that if you have got the luxury of time, you might use that time differently. But there isn't one answer to that question really, because it can involve so many variations on a presenting problem. But as the therapist, again, regardless of what your knowledge of ADHD, you could still formulate it within, if you are looking at the maintenance cycle, you are still looking at physical and emotional and cognitive factors, aren't you? And behaviors. So you are then building up a profile of what's happening for that person. And as you would with everybody, you then have to kind of theorize as to what's maintaining the problem, what can we work on first of all.
In terms of working with clients who have comorbid ADHD and are presenting at a talking therapy service, Helen, what would you say are things that therapists can work on with clients in the meantime to help manage some of those symptoms that show up for them?
Yeah, that's a really good question, because I think therapists might doubt their skill set. But if we think about, if we listen to the person with ADHD about some of the common difficulties they have day to day and create some goals around those difficulties, then it's absolutely helpful to work on those. So the main areas we're talking about, because disorganization is a main issue. And that can manifest in all sorts of different tasks or behaviors that are become difficult. So actually, there is a protocol by Stephen Safran et al., which has a reasonable evidence base, really, CBT for ADHD, and they target organisation, as a base, as a fundamental set of skills to try and instill in the person. Because if we think about ADHD, there are a lot of things that don't feel natural. And that is so that the disorganization, it's because that is the natural state. So we know the world values organization and organized people. So we're not trying to make people with ADHD be something they're not, but just to provide the skills that will make daily living more manageable. And even something that sounds simple, like a calendar, using a calendar effectively. With somebody with ADHD might have 10 calendars, all different ones, and, not have a system. So what we're trying to do when we're working with somebody with ADHD using CBT is to create some systems and routines that really then make those difficult tasks automatic. Because when something becomes automated, you take the thinking out of it. And with ADHD, we know that there is an overwhelm when it comes to jobs, tasks, even daily things that sound simple. So the demand creates a threat, and the threat creates a demand. So you get this overwhelm. So actually simplifying systems like calendars, like task lists, are really, really effective. They are your baseline targets, to hit, really. And when the person becomes more automated in keeping a diary, a to-do list that is actually effective, then it takes away a lot of day-to-day kind of stressors, because you feel more in control of those systems. And that alone can be it's a revelation. I mean, I can say, I've got one diary and it really works. And then you've got distractibility as a symptom cluster. And so you can work on that. And there are similarities with the distractibility techniques to some of the other techniques that CBT therapists already use, like worry delay. You've got distraction delay. And so, there are things to help a person remain on task. So we're going from all or nothing to little and often. So that's like task assignment, isn't it? When you break something up, if you're working with somebody with depression. So the skills are already there. You're just sort of like making them tailored to somebody who has difficulty staying on task. And then you've got thinking styles, which is very interesting to me, because there is a particular thinking style for people with ADHD, which was a revelation to me. And that was overly optimistic thinking, which is always thinking you've got more time than you have. So, before leaving the house, you'll do 10 things, which will make you half an hour late. Or you underestimate how long it's going to take to get from A to B. So, little tips like writing in your diary a leaving time rather than an arrival time, the other end, is helping you get out the house on time. So there's loads of things that you can do, anybody could do with a person with ADHD to really minimize some of those daily stressors. And then the emotional regulation will be obviously idiosyncratic, and there are clearly things that can help with that. But yeah, that's just a little flavour of some of the things that are possible, even in an IAPT service.
With that in mind, and just thinking about some of the challenges that people with ADHD face, and particularly the constraints that exist within the talking therapies model. So, like you mentioned, a number of sessions and a certain session length as well, and thinking that potentially someone with ADHD, for example, might tend to veer off topic on occasions during sessions, and maybe end up following tangents that maybe aren't necessarily related to the core issue being discussed as part of a session, for example. Ideally, how should that be handled in terms of recognizing, again, there's only a finite amount of minutes that generally the therapists have access to, and obviously we like a good agenda as part of CBT, and like a certain amount of time adherence and things like that. Shell's coughing because I am useless at time adherence in my sessions.
No, I'm coughing because actually this is something that came up this week, and Ravi and I have already had a little conversation about this. So part of my role at the minute, I'm supervising quite a lot of staff, including really new trainees. And I think working with clients presenting with ADHD is something that I really need to educate myself on. But I was asked a very specific supervision question this week, and my response came from an uninformed place, I think. So I used a practical part of my brain. And I said to my supervisee, perhaps you could talk with the client about reducing the session length, maybe 30 minutes instead of an hour, if that would feel easier for them. I also talked about kind of being quite rigid with the agenda. And actually, I felt like that was quite a good answer. But then I came and discussed it with Ravi, and he had a different kind of take on it, which was really interesting to hear. So I don't know if you want to share your point, Ravi.
Oh, I suppose mine was naming it in sessions in terms of firstly identifying if you're noticing that a client is veering off topic every so often. And I suppose even before that point in an early session, because I think we're in a position at the moment where clients are bringing up the topic of ADHD themselves. And to be honest, we're quite lucky with that in terms of them not only feeling as though they're in a safe space enough to mention that, but also be informed to say, hey, this is what I think is going on with me. And I suppose my take on it is to clarify, okay, well, what does that look like for you generally? What do you notice happens for you? And okay, if I sense that you're veering off a little bit and we're not kind of sticking to the topic, or if I sense that you're trying to engage in a little bit of avoidance, what would you like me to do at that point? Because I think that sort of helps to steady the boat a bit, and it stops it from being a bit of an awkward proposition later down the line when it happens. But granted, I think that depends on a lot of awareness in terms of, again, going back to that sort of Johari's window thing, it depends a lot on the client coming in and saying, hey, I've got this. And if we don't know that that's happening, obviously that presents another layer of the challenge on top of that as well.
Yeah, no, it's both really interesting and very valid answers to the supervisee's question. You know, they're both approaches that you take. I would say it doesn't necessarily be the ADHD patient who does that. I'm thinking people who present with GAD are the masters of this, veering off.
Absolutely.
So, you know, that was ingrained in me from a very long time ago. I don't have any qualms about saying, you know, stop, come back, or, you know, that sounds important, or is it? Sometimes it's not, you know. I can hear that, you know, and I name with GAD, I mean, and I will, you know, sort of like move back to the ADHD reference. But, you know, if somebody with GAD or any condition in the session is doing that, then we want to make sense of the function of it and what it's actually performing. It might be avoidance. It might be, so you are trying, or it might be something or what tends to happen, in my opinion, is that it's active worry and rumination playing out live. And I name that because whether they've got ADHD or not, you say, oh, it sounds like your head's really busy. And you don't even have to mention ADHD because you're not then labeling it or compartmentalizing it. You say, I'm hearing a load of chatter here. Is that what you hear normally inside your head? And that's how I would get at it. And I'll say, you know, so when you're inside your head, you're going like this, you know. But what about if we try and I'll do a grounding technique and say, let's see if that helps you sort of like stay on track with what we're talking about.
Oh, I like that. Thank you.
Yeah, I like that a lot as well. And I'm also really glad that you mentioned GAD there as well. And just thinking about, because this, obviously that's come up a lot over the course of our discussion today, and acknowledging that there is quite a significant overlap between the symptoms that someone would report for GAD and the symptoms that someone might report for ADHD. So things like, you know, the racing thoughts and the trouble concentrating and that sort of thing. And I suppose, what is the best way for a practitioner to maybe, I suppose, understand, approach and treat those, particularly if, and having been in services where people suspect they have ADHD and are awaiting an assessment, for example, but are coming in for treatment of GAD, what's the best way to make sense of those symptoms and the potential overlap between those two conditions?
Okay, so so we know that we all worry, so that is on a continuum. So, people with ADHD are likely to worry, more or less. So so we know that that's a normal, if you like, phenomenon or thinking process. So that's kind of one thing to bear in mind. To have GAD, it has to be excessive, doesn't it? And it has to cause symptoms of anxiety. So again, I would want to check out and how distressing are those thoughts, because actually with GAD, if it leads to anxiety, you can suggest that that's very distressing. Both of them will have high arousal in the brain as a result of all of that thinking. But for the person with ADHD, it might not be distressing or cause symptoms of anxiety. And also, it's how the person responds to all of that thinking, because the person with GAD is likely to use a load of safety or avoidance behaviours. The person with ADHD, you'd want to know how they respond to those racing thoughts. They might get dead excited and go out or spend money or do something. It might not be responding in the same way, and you've got to map that out, haven't you, on a cycle in order to make sense of that. What's the response to that? And so, yes, lack of concentration or, racing thoughts in and of themselves, you could say sort of both would experience, but the actual lived experience of the two is likely to be very different. But of course, you can have both as well, which is always a possibility, isn't it?
How would someone navigate that? If someone has both GAD and ADHD, that sounds like it's almost like kind of like a bunch of shoelaces that are kind of just all jumbled together a bit, and separating out those knots seems like it would be quite a challenging task for not only for the person themselves, but also in a therapeutic environment for both people involved in that conversation to get a full understanding of what's going on.
Well, like any comorbidity, you would really find out what is the sort of like having the most impact, what is the thing that the person wants to work on, bearing in mind that ADHD is a lifelong condition, GAD doesn't have to be. If you're taking away the GAD from the equation, then you would hope that would reduce the ADHD symptoms anyway. Not necessarily. It's not that simple, of course, but does that make sense?
It does. And I liked how you explained that. And I could see a therapist and a client kind of coming to that understanding together as well, to explain that ADHD is your lifelong condition, but actually this bit needn't be. And maybe this is the piece that we can kind of work on and change. And the knock-on effect might be that your other symptoms reduce as well. I really like that. So it's a very simple way of explaining it, and it's kind of made more sense in my head as well. Because very much like Ravi was saying, I was thinking, when you were talking about fight, flight, freeze earlier, I was thinking, well, yeah, we see that every day with common mental health conditions. So how do we know if that's their mental health condition in play or their neurodiversity in action? But that was really helpful. Thank you.
Good.
Totally. And just as a final question on I suppose ADHD and working in IAPT, is there any sort of final hints or pieces of advice that you'd give for either therapists or trainees on their training journey about working with comorbid ADHD? Anything final that we'd like to add?
I think, well, for trainees, it's always a minefield. There's so much to learn that, I think it's always a very stressful time, isn't it? So when you've got a therapist and or a trainee who's highly aroused, that's probably not a good state to be in when you are working with somebody who's also highly aroused. So I would say grounding, be realistic in what you can sort of like do with a person, and just use your skill. You've got the skills and the knowledge to help anybody, to be honest with you, and not saying that, that there is issues to do with competency, of course, and there might be blind spots in a person's knowledge, but if you've passed the course, that CBT training, it takes, we know on average 8 years to become a CBT therapist. That's a lot of experience and skills, and people are often very lack confidence at that point, when really it's a highly skilled job. So knowing that, grounding yourself and just looking at what's in front of you in that present moment, rather than all of this, or else you've got two people like highly aroused and bouncing off each other. So I would always say that just take your time, slow down and really have a good examination. Take your time, because what's the worst that can happen? If you rush through it, you might not actually help the person as much. And a good formulation, in my view, is the best gift you can give somebody, because they could drop out at any point. And if they've got the formulation, they can always come back at a later date. The formulation helps to make sense of something that's been eluding them or confusing them for years. So to me, it's all about using that time to create that. And to me, that's the kind of gift.
Definitely. I think those are really good piece of advice, actually. And it's interesting, as you were talking there about formulation, I completely agree with you. Formulation are definitely the keys to my heart at the moment. And I always find it really interesting, actually, because I remember doing some transdiagnostic or having some transdiagnostic teaching where I think in Barlow's model, they sort of got rid of the formulation part of things because they said that it didn't really serve any particular help for the client. But I think if anything, that's the vital map that kind of guides us both on that particular journey. So I definitely agree in terms of the importance of that. And just a final and maybe slightly more personal question from me, Helen. You spoke earlier about the assessments that you've had in the past. And I must admit, listening to you, I felt really inspired, because being neurodiverse, there's an element of kind of having sort of special superpowers sometimes that kind of comes with it, in terms of just being able to sort of think laterally in terms of an ongoing career journey, or for therapists listening who are neurodiverse. How can they kind of balance that, having, experiencing neurodiversity alongside a career that is arguably quite demanding, requires a lot of skill and capacity in terms of the workload that we put in? How should people experiencing those things kind of approach it, and what advice would you give them to kind of continue to thrive doing this role?
That's a lovely question. It really beautifully put, Ravi, as well. So I would say I'm very, very, very lucky that I found a passion, and I think it's all about having a passion for what you do. So I didn't do particularly well at school. And to be honest, funnily enough, knowing myself as I do now, it didn't really bother me that much, because I kind of had this sense that I knew that I was quite bright, but that school wasn't geared up for my kind of learning. And I still think it's the same, actually. It wasn't geared up for my kind of thinking or learning. And I always kind of felt a little bit kind of smug about that. Like, I'm not stupid. So I'm lucky that I didn't develop that. I developed a lot of negative beliefs, but that wasn't one of them. So when I did leave school, I was unsure what to do, and then I became a learning disability nurse. And and the first term of doing that training, I was introduced to psychology. And it was 1986. I'd never heard of psychology before then. And it lit me up. And I started my love affair with psychology in 1986. And it's been the thread throughout my career of over 35 years that I have just That's my hyper focus. I couldn't go on Mastermind and do general knowledge, but I could answer anything about mental health or psychology, because that's how it's been all my career. Whatever I've done, it's been around psychology, mental health, learning disabilities. So if you find that passion, it doesn't matter what it is. I think that's the thing that's kept me really focused on whatever I've done.
Oh, that was so gorgeous.
It was.
I love that. And you're so passionate when you speak. It's really engaging. So yeah.
Thank
Yeah,
you.
that was definitely very wholesome and heartwarming to hear, and your passion is both immense and evident as well. So I want to thank you for not only that, but also for your time today, Helen. And just before we end the discussion today, just remind us where people can find out more about you.
Yeah, so there's obviously my website, moyacbt.co.uk. There's a lot of information on there. Obviously, we've mentioned the resources page, and the training details are on there. But I also have a Facebook group called CBT Careers, and there's 2,000 members. I started it in lockdown because I really wanted to give the information to people wanting to pursue a career in CBT. So that's a nice place to sort of like ask questions or find out information as well. So they're probably the two things I would say. I think that's it.
Fantastic. Well, just once again, thank you very much for your passion and your time today, Helen. And we hope we can catch up again soon.
Thank you, Helen.
Thank you so much. Thank you for inviting me.
So, Shell, what an amazing guest Helen was. I really enjoyed that.
It was incredible. I mean, I think I said to you at the beginning, this is an area that I have no knowledge, that's not true. Some knowledge, but limited. And it's all been kind of on the job learning, I'm kind of, not in a position to have had any lived experience or even really kind of know people who live with neurodiversity. So it's always been a bit mystical to me. And I've just found that so interesting. And it's going to be incredibly useful for people who are training or are qualified and have been qualified for a number of years and still feel a little bit overwhelmed in how best to support clients who are in distress and struggling.
100%. I think what you said in the interview about kind of gaps in our knowledge and the fact that I feel like we're at this point where, granted, the amount of people who are seeking support for ADHD has skyrocketed over recent years. I think that the system is, as we said in the interview, definitely playing catch up, which is part of the reason why we probably don't get the training that we need on it as of yet.
That was a really good point.
Yeah, and I think that hopefully this is the one piece in the puzzle of change. If there are any other topics that you would like to hear us cover on Two Lost Souls, please reach out to us on Twitter at TLS_pod or by email at twolostsoulspodcast@gmail.com. And you may just feature in a little segment that we like to call Socratic Questions. And funnily enough, alongside our Twitter and email platforms, you can, if you listen to us on Spotify, leave us a voice note. And funnily enough, as part of our last episode on staff wellbeing in IAPT services, or talking therapy services rather, we had a voice message left for us by Sharon O'Gillian.
Hi, I just wanted to make a comment because the hierarchy within modalities isn't right. I respect CBT and it's really important, But there's other modalities within the IAPT service. There's counselling, there's interpersonal psychotherapy, there's lots of other modalities, and I just wish that somebody would recognise them and make them as important as CBT, especially within an IAPT service. All the modalities are important, and it allows the clients to have a choice. So I just want to see the other modalities recognised and respected as much as CBT. Thank you for your time.
I think Sharon makes a really interesting point, doesn't she? And I mean, I completely agree with her. CBT has been the prominent therapy choice for the NHS over the last 15 years or so. But more recently, I mean, particularly our service, we've definitely expanded to increase those non-CBT offerings at high intensity level. So PCE counselling. I think if we think back just 4 or 5 years ago, when we had kind of enhanced primary care counsellors, but they weren't IAPT compliant. And then there was this big kind of move over to help make those professionals kind of become IAPT members of staff, but they had to do a whole piece of retraining, and services needed to support that. Some of those counsellors moved away from counselling and moved into modalities like IPT, DIT and CBT. I'm one of them. I moved away from counselling and became a CBT therapist in order to become IAPT compliant. If I'd waited 2 years, I may have gone down a PCE route, but that wasn't an option at that point. So we haven't really had a lot of time to build on the modalities within IAPT or talking therapies as they are now. It's still quite new, but it's definitely getting there. I'm starting an MBCT course this month. So, you know, who'd have thought that we would have had, you know, mindfulness within IAPT even 5 years ago? It just wasn't heard of. But unfortunately, the podcast that we're doing is to support CBT trainees. So obviously, I think it's right that that's where our bias lies. It's what we've got the most experience in, I guess. And it's kind of, you know, what we're aiming to talk about. So, yeah, I do agree that, you know, we possibly could focus a little bit more on the other modalities, but for our trainees, I suppose we are keeping it more CBT focused. What do you think, Ravi?
Yeah, totally. I couldn't agree more. I think you've hit the nail on the head there, really. I know that I work with a team of people who work within a range of really diverse modalities, actually, particularly at high intensity level. And there are a wide range of therapeutic strands available for people to make use of, which I think is actually a really nice thing, knowing that I think there's this misconception sometimes that within the NHS, CBT is this one-size-fits-all solution. Having kind of seen behind the curtain, as it were, I think there's a lot to be said for the fact that there is more on offer than it looks from the outside sometimes. And those professionals do a great job and they work really hard alongside us. And to be honest, we couldn't do our jobs without them, because we all kind of rely on each other a little bit to do what we do and keep a service running, and give an offering to clients with sufficient diversity and variety to meet the needs of the population that we serve. However, as you said, this is Two Lost Souls, a podcast for trainees on the high intensity CBT program. But thank you for your voice note. And if you get in touch with us about any future content that you'd like us to cover, please give us a shout on our usual line. So that's TLS_pod on Twitter, or at Two Lost Souls podcast at gmail.com. So, if you have taken anything away from this episode of Two Lost Souls, please hit that subscribe button on your podcatcher of choice and recommend us to your friends. It really means a huge amount when you do that. Alternatively, if there's anything you would like to see us discuss, give us a follow and drop us a line at TLS_pod on Twitter or at twolostsoulspodcast@gmail.com. All that's left to do, first of all, is say a huge thank you to our guest for this episode, Dr. Helen Moya, for her time and for her expertise and passion on the subject of ADHD. And also say a massive thank you to you, Shell.
Thank you, Ravi.
You're very welcome. And thank you all for listening. We hope you've enjoyed this episode, and we'll see you next time on Two Lost Souls.
Two Lost Souls was presented by Ravi Amrath and Michelle Sudbury. To get in touch, contact TLS_pod on Twitter or email twolostsoulspodcast@gmail.com.